Saurabh, can you just allow me to share my screen?
Just give me 1 second. I will make it live. Okay, so we are live. Hi, good morning, everyone. Good evening, good afternoon for a lot of other countries and places where we are joining. We are live on 109th session of CIMAO International Weekly Meeting. We meet every Saturday with the National Medical Associations of about 19-20 countries. And we share a platform where we can share knowledge. We've all gone through a tough time, pandemic of COVID, which is still on. Cases are rising. So it's very important for us to understand what's going on with this and what's going on with the vaccination and how we can prevent ourselves. To talk about this topic, we have Professor Shabir Madhi. He's from South Africa, a well-known person, a whole list of credentials with him, but I will introduce him by, he's a vaccinologist, a pediatrician, he's a dean for Wits Medical School in Johannesburg, he's a researcher, a principal investigator of vaccine trials of Pfizer, he's a former head for NICD of South Africa, he's a very important member for WHO Strategic Advisory Group, expert committee of SAGE. I would invite Professor for taking the session over here.
So, good morning, everyone, and thanks for this opportunity. So what I'm going to do over the course of the next half an hour or so is firstly just to touch on briefly on the epidemiology of COVID-19 in South Africa, but also to put it into context on the African continent as to what has happened and to what extent we really understand the impact that COVID-19 has had in Africa. And then I'll touch briefly on the issue of the Omicron variant, as well as how it turned out in South Africa, including the data around vaccine effectiveness, and some lessons which have been learned during the course of the experience with the Omicron wave, which I believe is important to keep in mind as we move forward during the course of this pandemic. And in particular, the type of decoupling which we observed in South Africa, which really speaks to what we perhaps did and did not do correctly in the past, including when it comes to vaccine rollout. So these are data which are a bit outdated from the 13th of April, but the essence of it remains pretty much unchanged. So around about the middle of April of this year, globally there were about 500 million cases of COVID-19 which have been reported. What notable was that just about 2.5% of these cases were actually recorded from Africa. Now, Africa constitutes 18% of the global population, yet they were reporting about 2.5% of all of the cases on the continent. When you look at Africa more deeply in terms of the recorded number of cases, roughly about 40% of all of those cases are being reported from a single country, and that is South Africa. So South Africa constitutes around about 5% of the African population, yet is responsible for reporting 40% of all of the COVID cases that have been documented. Now, the major reason for this is that if we were just to look at COVID-19 reported cases, what we would see is that South Africa has got an incidence which is not too dissimilar to many other Northern Hemisphere countries, perhaps a bit lower, whilst for the rest of Africa, you've got incidence that is extremely low per million of the population. And what underpins this is really vast differences, heterogeneity, when it comes to the amount of testing that's done on the continent. So even in South Africa, which does amongst the highest testing across the entire continent, the amount of testing that's done per thousand of the population is about 20 times lower than the amount of testing that's done, as an example, in the United Kingdom, and about 6 to 7 times lower than the amount of testing which is done in the United States. So what we're experiencing across the African continent, and including in South Africa to some extent, and I'll show you data that supports this, essentially is an underascertainment of the impact that COVID-19 has had, both with regard to cases and obviously consequently with regard to COVID-19 death. Now, the reason to believe that there has been systematic underascertainment of the case rate are a number of sero-surveys which have been conducted over the course of the past 2 years. And this is an analysis of sero-surveys that were undertaken until the middle of November 2021. And this is before the onset of the Omicron wave. And what we see across the continent is that, across the globe, is that the continent with the highest seropositivity, in fact, is Africa, sitting at 79%. What we see based on the sero-surveys is rather than 500 million people having been infected with the virus, the estimate based on the sero-surveys where about 44% of the global population have been infected at least once. And again, to emphasize, this was before the onset of the Omicron wave, results in about 3.4 billion people having been infected with the virus already by the middle of November 2021. The highest case rate basically sits in South Asia at 1.34 billion, largely because of the higher population size in that region of the world. So when it comes to the number of people that have actually died of COVID-19, globally, around about April as well, the number of people, middle of April, the global number of recorded cases was sitting at 6.2 million. And as you can see, Africa was only constituting 0.25 million of those cases, 250,000. Of those 250,000 cases that were being recorded from Africa, fatal cases of COVID-19, 100,000 of those, again, were recorded from a single country, and that is South Africa. And like I mentioned, South Africa only constitutes 5% of the African population. So why do we believe that the systematic underascertainment of COVID-19 cases is premised on the experience in South Africa as well as other African countries where there's been reasonable amount of reporting? And what we basically see is that when looking at the case rate per 100,000, the death rate per 100,000, low and middle income countries, in fact, have got a substantially higher COVID-19 mortality rate than high income countries and upper middle income countries. South Africa is an upper middle income country, yet our case fatality rate per 100,000, in fact, is substantially higher than the average that's been reported for other middle income countries, as I'll show you. So globally, there have been 6 million cases of COVID-19 death reported, and a review of the data around about the middle of November 2021 using the excess mortality data now, estimated then already, and again, this was before the onset of the Omicron wave, that the number of deaths that had transpired from COVID-19 was probably already closer to 15 million. And these are data which were reported and somewhat agreed upon by the WHO yesterday. But again, to emphasize, this was before the onset of the Omicron wave. Now, what we see in South Africa, and like I mentioned, when we look at the mortality per 100,000, for upper middle income countries is being reported at 200 per 100,000, for low middle income countries just over 300 per 100,000. In fact, in South Africa, when using the excess mortality data, what we're sitting at is an excess mortality of 520 per 100,000, and this is excess mortality from natural causes. When you go across the continent, and these are data now until the 30th of April 2022, when you go across the country, there are some parts of the country, such as the Eastern Cape, which is a relatively rural setting, where the excess mortality that's been reported is sitting as close to 650 per 100,000. And I'll show you how that ranks compared to excess mortality estimates attributable to COVID in other countries in the next slide. And what you see with this excess mortality, there is a narrative that not all of this excess mortality is attributable to COVID-19, and that is possibly correct. But at the same time, when looking at this excess mortality and when it's occurring in relation to the actual recorded death, you find that this excess mortality spikes are very much synchronous with the recorded COVID-19 death. So the recorded COVID-19 deaths in South Africa as of the 30th of April was at about 105,000. Excess mortality gave an estimate closer to 310,000. But the synchrony of these trajectories really suggests that, in fact, the majority of this excess mortality, and I would venture that probably 90% of this excess mortality is attributable to COVID-19. it cannot be attributable to other conditions because we wouldn't expect the same sort of the synchrony of this trajectory were it because of other medical conditions. I do believe that as we move forward, because of there being because of there not being adequate focus on many other chronic conditions, including the delayed diagnosis of tuberculosis as an example, interruptions of treatment for TB, for HIV, for other chronic diseases, that beyond the pandemic and in the next year or so, we probably will continue seeing higher excess mortality, which now will be less attributable to COVID, but rather excess mortality due to poor management or interrupted management of these chronic conditions. So where does excess mortality, what does excess mortality tell us about other countries and the extent of underestimation? And this is an analysis that was just released yesterday. Using the United Kingdom as a reference, and the reason for that is the United Kingdom, the excess mortality and recorded number of deaths is very much almost identical. And using that as a reference, what we find is that a country such as South Africa, and as I just showed you, probably underreports COVID-19 deaths by a factor of about 2.6. But then when you go up, many other countries, and this is only limited to analyzing countries where at least 10,000 COVID-19 deaths have been reported. In many African countries, they haven't even reached this threshold, not because those deaths haven't necessarily occurred, but rather because of the underascertainment of those deaths. So they basically excluded from this analysis. As we move along, we find that in a country such as India, the estimate is that the recorded death underestimates the number of COVID-19 deaths that have likely transpired by a factor of 10. In Egypt, by a factor of 11.5. So systemic underreporting of COVID-19 mortality across the globe are largely because of challenges when it comes to testing, as well as issues when it comes to access to healthcare facilities, with healthcare facilities having been overwhelmed in many, many parts of the world, including some high-income countries. Large numbers of patients, including South Africa, didn't even make it to healthcare facilities and unfortunately demise outside of healthcare facilities. This is not unique to COVID-19. In a place such as South Africa, as an example, historically what we've seen is that close to 40% of children under the age of 5 actually don't die in healthcare facilities. They die at home. So those cases obviously wouldn't be investigated, and you wouldn't really know the reason why they died outside of the COVID pandemic. During the course of the COVID pandemic, when those deaths are aligning to the surge of cases of recorded COVID-19, then we can be fairly confident that those deaths are possibly related to COVID-19. So using these cases, and this is looking at excess mortality per 100,000 as of middle of April again, where we're sitting is that South Africa's excess mortality is sitting, like I mentioned, substantially higher than other upper middle income countries. It's about 420, 430 per 100,000. This is assuming that about 80% of the excess mortality is due to COVID. India basically is sitting in the region of about 3 to 4 million, the total number of COVID-19 attributable deaths in India is in the region of about 3.5 to 4 million. Per 100,000 is sitting almost identical to where South Africa is sitting. Compared to a country such as the United Kingdom, where even using excess mortality to measure COVID-19 attributable death is sitting at about 200 per 100,000, half or 50% compared with what exists in South Africa and India. So upper middle income countries and middle income countries, including India, South Africa, have not been spared from COVID-19. If anything, the COVID-19 death rate in these countries is substantially higher than in high income countries. Now, with that in a backdrop, what we see when it comes to COVID-19 vaccine rollout is a huge amount of inequity, and this has existed since the start of the rollout of COVID-19 vaccines around about November of 2020 already. Across the African continent, many countries have still not even vaccinated 20% of the population. There are some countries which are yet to vaccinate even 5% of the population. A country such as South Africa, which started to roll out belatedly COVID-19 vaccines around about June of last year, 1 year later, we have not yet even reached 50% of our population. And most importantly, perhaps in my mind, is that even in individuals above the age of 50, we have now just reached around about 60% of that age group who contribute to more than 80 to 85% of all of the deaths that transpires from COVID-19. But at the same time, as I mentioned earlier, there has been a fundamental shift with regard to the population immunity against COVID, and particularly against severe disease and death. And that immunity has evolved, not so much so because of rollout of COVID-19 vaccines on the African continent compared with what has happened in West Europe, in North America, South America, but rather immunity that has evolved because of infections. Large force of infection, 80% of the population have been infected at least once since the start of the COVID pandemic, and that was even before the onset of the Omicron wave. And I'll show you the importance of that infection, which has come at tremendous cost. Like I said, 15 million people were estimated to have died already by the middle of November of 2021. So there's been large numbers of infections, but that has come at a huge amount of cost. But at the same time, those infections are immunity inducing, and we can't dismiss it, because as I'll show you, the data points strongly that infection-induced immunity probably works reasonably well, especially when it comes to protecting against what matters most, and that is severe COVID. So what happened in South Africa, and what were the reasons for this delay of COVID-19 vaccine rollout? And in fact, what was the implications for some of the decisions that were made, which in fact went against the WHO recommendations at the time? So the first doses of COVID-19 vaccine in fact arrived in South Africa on the 1st of February 2021, before the onset of the third wave. And these doses of vaccines were procured directly from the Serum Institute of India, and at a time when the Indian government were actually restricting export of the AstraZeneca vaccine because of wanting to prioritize its own population, and probably because of engagement at the highest level of government. These 1.5 million doses of vaccine were actually eventually received in South Africa. But what happened is that the day that these vaccines were received, we basically analyzed a study that we were conducting, looking at the efficacy of the AstraZeneca vaccine in the South African context. And by the 1st of February 2021, what had happened in South Africa is that the beta variant had evolved. And the beta variant was relatively antibody evasive, especially to the type of antibody that was being induced by the first generation COVID-19 vaccines, including the AstraZeneca vaccine, as well as many other vaccines, where there was about an 8-fold reduction in the neutralizing antibody activity induced by those vaccines against the beta variant. So what we showed in South Africa, almost to the date when the AstraZeneca vaccine arrived, was that the AstraZeneca vaccine did not protect against mild to moderate COVID-19 due to the beta variant. The point estimate was 10%. Overall vaccine was about 22%, vaccine efficacy was 22%, but obviously these are completely non-significant, large confidence intervals. But important to emphasize, and we mentioned this at the time of the release of this data, is that we didn't have any severe cases of COVID-19 in this particular population that were enrolled into the study, who were relatively healthy individuals. But we showed no efficacy against mild to moderate COVID-19 due to the beta variant. And that didn't come as a surprise, because 1 or 2 weeks earlier, what we had also demonstrated, in fact, was that there was very little neutralizing antibody activity in those individuals that had received the AstraZeneca vaccine. So for the beta variant, close to 85% of individuals had no neutralizing antibody activity against the beta variant, compared to 100% of individuals having neutralizing antibody against the wild-type virus. So this didn't come as too much of a surprise that we didn't show efficacy. Now, despite that data, the WHO, at the same time, what we were able to show, and this was reported in the same study, is that despite this diminished neutralizing antibody activity that was being induced by the vaccine, what was being relatively preserved and largely unaffected was the T-cell responses. So looking at the CD8 responses, the CD4 responses, the vast majority of these responses, which are polyepitopic by nature, targeting close to 87 different spike epitopes, those T-cell responses against those epitopes were largely conserved. 76 out of 87 epitope inducing T-cell responses were basically unaffected by these mutations that had transpired in the beta variant. So we now have a situation very similar to what we're experiencing with Omicron, as I'll show you. is we've got the variant that is highly antibody evasive because of multiple mutations in the RBD and the NTD, but at the same time, the T cell responses are being relatively conserved against these relatively antibody evasive variants. Now, based on these data, together with some animal model studies that came out around about the same time, the WHO recommended that even in countries where the beta variant was dominating, those countries should continue using the AstraZeneca vaccine, because biologically there was indirect evidence which still showed that the AstraZeneca vaccine could protect against severe COVID, despite the disappointing results of the South African study. But like I mentioned, rather than using the vaccine, South Africa's government and some advisors decided not to use the vaccine and sold off the vaccine to other African countries where the beta variant was also dominating. So here we had a situation where there was limited opportunity to get vaccines. The vaccines were known to be safe. The WHO was saying that you still need to use these vaccines even where the beta variant is circulating. But rather than using these vaccines and targeting it to those that require it the most, and those are people above the age of 50, South Africa decided not to use the vaccine. And I'll show you what the consequences of that sort of decision-making has been. Subsequently, in a study from Canada, in fact, the study basically demonstrated that the WHO advised, had we adhered to it, we would have been able to protect a substantial number of people and prevent substantial number of deaths from transpiring in the subsequent waves. So in this Canadian study looking at the AstraZeneca vaccine, 14 days after the first dose, the vaccine effectiveness against the beta or gamma variant was estimated to be in the region of 80%. So 80% reduction in severe disease due to the beta or the gamma variant, whereas this AstraZeneca vaccine didn't have any protection against mild to moderate COVID-19. So when we think of COVID-19 vaccines, we really need to understand why we're using these vaccines. And we need to set the goal as to the purpose we're using this, as to the reason we're using these vaccines. When we talk of vaccine efficacy, we sort of get, it becomes obfuscated by being unclear whether we're just talking of all symptomatic disease, including asymptomatic infections, or focusing on severe disease. And the current generation of COVID-19 vaccines, as the data shows, really are vaccines that work best and are most resilient in protecting against severe disease and death. So what was experienced with the Omicron wave in terms of immune responses as well as vaccine effectiveness? So South Africa was the country, together with Botswana, where the Omicron variant was first reported around about towards the end of November 2021. And that resulted in a huge amount of panic across the globe, including with many countries shutting their borders to southern African countries with the false belief, and it appears that they hadn't learned anything from the past experience. So even during the course of the beta variant, where countries embarked on the same sort of strategy of shutting their borders, what they simply failed to understand is that although the beta variant was only reported in South Africa around about the middle of November 2021, as you can see from the sequencing data, the evolution of the beta variant took place already around about September 2020, but was only reported in November 2020. That's when it was first identified. So by the time we actually identified these variants have already been circulating for weeks. The only reason we only identifying these variants at a later stage is that we only start becoming more focused on increasing our sequencing or having sufficient numbers to sequence when there's an increase in the number of cases. So when the case rate is low, there's very little sequencing that's been done because the number of cases that are coming to the lab are fairly limited. Now, the same thing applies to the Omicron variant, that by the time that we actually identified it, it probably had already been circulating for a few weeks before. So shutting your borders only at a time when a variant is first being reported basically is agnostic to the reality that this variant has already been circulating and is probably already dispersed. So that's what we experienced with the Omicron variant. And more recently, what we're now seeing is that as the Omicron variant subsided, we saw an increase in the sublineages, including the BA2, which didn't get too much traction. It started to increase, but then dissipated fairly rapidly. And more recently, we're getting an increase in the BA4 and BA5. And I'll show you some of the data regarding the trajectory of COVID-19 in relation to the BA4 and BA5 sublineages. So like I mentioned, South Africa reported it toward the presence of the Omicron variant towards the end of November 2021, and 2 weeks later, despite all of these countries, Northern Hemisphere countries, many other countries shutting their borders to South Africa and Southern African countries selectively, the Omicron is already dissipated across the globe. And this should be a lesson that when there are variants that evolve, shutting your borders to a handful of countries simply is not going to achieve anything. If you want to shut your borders, you need to basically shut your borders to the rest of the world. Because just shutting your borders to South Africa doesn't minimize the chances of the variant ending up in the United Kingdom, because travelers to India will still be coming to South Africa, going back to India and going to the United Kingdom as an example. In addition to which, like I said, by the time you identify these variants, in all likelihood, these variants have already dissipated into many other countries. Now, the reason for concern with the Omicron variant was firstly because the mutations indicated that it would be relatively antibody evasive, in addition to which there were some mutations suggesting that it would be much more transmissible than other variants. And there was also a suggestion that it might be able to evade innate immunity. So what did we experience for the Omicron wave in South Africa? What we experienced is that it very likely was more transmissible, because the incline of this trajectory was much steeper than anything that we had actually experienced in the earlier waves. But at the same time, it increased much more rapidly and participated more rapidly with a longer tail compared with other variants, as well as the wild type virus. So what we experience is a suggestion that this variant was much more transmissible. The variant was much more transmissible than earlier variants. And at the same time, it probably resulted in a large number of cases. And there probably was an under-documentation of the number of cases that occurred during the course of this particular wave compared to earlier waves, because of a lower number of tests that were also being performed. What was also remarkable with this particular variant was that at the time of the peak of the resurgence, the positivity rate that was being recorded was close on to 50%, something that wasn't experienced in any of the earlier waves, including with the Delta variant wave. And the reason why this is important is that when we looked at pregnant women that were coming to hospital as an example to deliver babies that were completely well, the positivity rate in pregnant women that were completely asymptomatic in many facilities was sitting at about 30%. So in addition to the recorded number of COVID-19 cases of symptomatic illness, there were also a large number of cases that were largely going undetected, because this was a virus that was disseminating across the country extremely rapidly and infecting people, with large numbers of people being asymptomatic. There was a household survey study that was done in South Africa before the Omicron wave, which actually reported that 85% of infections in that household survey, where sampling was taken almost on a weekly basis in South Africa before the onset of the Omicron wave, were asymptomatic infections. What else did we learn at an early stage with the Omicron variant is that, unsurprisingly, given those mutations that had occurred, is that vaccines, whether it was the messenger RNA vaccines or the AstraZeneca vaccines on its own, as well as sparse infection on its own, when it came to the Omicron variant, there was almost no neutralizing antibody after 2 doses of these vaccines, or sparse infection due to the Alpha variant, the Beta variant, or the Delta variant. Whilst infections with those variants still induce some cross-reactive neutralizing antibody activity against other variants, when it came to the Omicron variant, irrespective of which variant you had been previously infected with, there was very little presence of neutralizing antibody. And like I mentioned, the same thing for the messenger RNA vaccines and the AstraZeneca vaccine. You basically see in the red that very few of these patients, in fact, almost none of them, had presence of neutralizing antibody. But at the same time, you could overcome some of that antibody evasiveness by boosting your immune responses. And this was the case for, as an example, the Pfizer vaccine, where 1 month after the second dose, some individuals, and this is before you get substantial waning of the antibody, some of those individuals, about 50% of them, had some neutralizing antibody activity against the Omicron variant. But more importantly, and this is an important because the reality in the South African context, the Indian context, and many other low middle-income countries is that large percentage of the population have now been infected with the virus. And what we see with this sort of vaccine plus infection-induced immunity is a very, very different sort of dynamics in terms of very different dynamic when it comes to, my apologies, just give me a second, please. So when it comes to this hybrid immunity, we see a very different sort of a picture evolve with regard to the kinetics of the antibody and the amount of neutralizing antibody that still exists. So what we see with hybrid immunity is that in fact the substantial amount, the large majority of the cases that were investigated still have neutralizing antibody activity against the Omicron variant. In addition to which, individuals that have had a heterologous schedule, AstraZeneca together with Pfizer, which we know induces greater magnitude of antibody response than a homologous approach, also still have substantial amount of neutralizing antibody activity against the Omicron variant. Now, although there is a diminished neutralizing antibody activity, as I mentioned earlier, what we do also experience is relative conservation of the CD4 responses as well as the CD8 responses. So less than 15 to 20% of the CD4 and CD8 responses are actually affected by the mutations that have materialized with the Omicron variant. So we've got a situation that vaccine-induced immunity, although there's greatly diminished neutralizing antibody activity against Omicron variant, there's largely preservation of the T-cell responses. And this doesn't only apply to the vaccine-induced immune responses, but also applies to infection-induced responses. So irrespective of whether they were previously infected with a wild type, the alpha, the beta variant, or the delta variant, the CD8 and CD4 and CD8 responses that are induced by those particular past infections. And again, they're even more polyepitopic in that they're not only targeting the S protein, but also targeting the N and the M protein. Those CD4 and CD8 responses from past infections are relatively conserved against Omicron, despite the multiple mutations that have transpired in the spike protein of Omicron. So what did this turn out with regard to its impact on vaccine effectiveness? Unsurprisingly, what was reported in South Africa for the Pfizer vaccine is that whilst effectiveness against all severity illness, symptomatic COVID-19, diminished from 80% for the Delta variant wave that was before Omicron to 33% against Omicron, what was less affected was vaccine effectiveness against severe disease. And I'll show you that data. This waning of effectiveness against symptomatic COVID of all severity also depended on the time when you receive, compared with when you had received the last dose. And obviously the reason for this is because of the waning of antibody over time. So you had to receive your second dose of Pfizer vaccine more than 3 to 4 months earlier, then protection against symptomatic COVID, which was not significant, was sitting at a point estimate of 25%, compared to a point estimate of 56% if you had received the second dose of Pfizer vaccine at least 2 to 4 weeks earlier. So how is Omicron? So in the South African, in the same study, the reported efficacy against hospitalization due to COVID for the Pfizer vaccine was at about 70%, compared to as closer to 90% for the Delta variant wave. But I want to rather go to the study which came out from Qatar, which also looks at effectiveness of the vaccine as well as of past infection against symptomatic COVID-19 due to Omicron, as well as against hospitalization. And I think there's important lessons to be taken away from the study, which really needs to influence how we think of COVID-19 vaccines moving ahead, as well as what it means when it comes to the issue of rolling out COVID-19 vaccines, especially in countries where there's been limited rollout of vaccine. So what they reported in the study from Qatar is that individuals that had prior infection without any vaccine, their protection against Omicrons or severity illness was sitting at 50% compared to no vaccine efficacy for the Pfizer vaccine for those that had already received 2 doses of vaccine. If people have had hybrid immunity, the effectiveness against symptomatic Omicron illness was sitting at 52%. If they had 3 doses, that had gone up to 60%. If they had hybrid immunity and 3 doses of the messenger RNA vaccine, the Pfizer vaccine, that goes up to 75%. And this is for all severity illness. So we see a difference in terms of vaccine effectiveness for past infection being actually better than 2 doses of the messenger RNA vaccine in the absence of past infection. And that speaks to a greater depth and breadth of immune responses that are induced by infection compared with vaccines only. But like I mentioned earlier, we're now very much in a world where the majority of individuals, especially in middle-income countries, are actually having hybrid immunity because of the large force of infection that has transpired. But when it comes to effectiveness against hospitalization, almost identical to what was seen with the Beta variant, is that despite vaccines not necessarily protecting against all symptomatic illness, protection against hospitalization was consistently high, irrespective of whether it was past infection, 2 doses of the Pfizer vaccine, hybrid immunity with 2 doses or 3 doses, sitting in the region of 96 to 100%. And a very similar sort of picture being seen with a BA2 variant, the BA2 sublineage, almost identical picture to what was seen for the BA1 lineage, except that the confidence intervals here for severe disease are much wider. And this is a subsequent analysis, again, from Qatar, which basically compares past infection compared with 2 doses of either the Pfizer vaccine or 2 doses of the Moderna vaccine. And the summary of this that is shown at the bottom is that past infection, in fact, in this analysis from Qatar, performs better than 2 doses of these vaccines, both against symptomatic illness as well as against severe COVID-19. And I don't think we can wish this data away. Like I mentioned, I'm not advocating that people get infected. It comes at a cost, huge loss of life, long COVID, etc. But the reality is that these infections have now transpired, and there's no wishing it away. These infections have transpired. It does confer immunity, and especially conferring reasonably good protection against severe disease. But we can do better by getting people vaccinated, because a hybrid immunity seems to perform best when it comes to protecting individuals against symptomatic illness as well as against severe disease. So what did we see with Omicron in South Africa, and what type of decoupling? So Omicron arose at a time in South Africa where only about 1/3 of the population had received at least a single dose of the vaccine. In fact, in the 12 to 18-year age group, it was 11% that had received a single dose of vaccine. In the greater than 50 age group, about 61% that received only a single dose of vaccine. 2 doses of vaccine in the greater than 50-year age group are sitting at less than 50%. And obviously, this is a group, as I mentioned, that are responsible for the majority of deaths that transpires not from COVID-19, not just in South Africa, but globally. But what we also showed is before the onset of Omicron wave, fortuitously, we were completing a second round of a serious survey in Gauteng, which is a province in South Africa where 1/4 of the population live. And what we showed before the onset of the Omicron wave is that in unvaccinated individuals, even in children under the age of 12, who were completely unvaccinated, obviously 55% of them were seropositive. When looking at an 18 to 50-year age group, close to 70% of unvaccinated individuals, including those above the age of 50, who are unvaccinated, were seropositive. Unsurprisingly, those that were vaccinated had a higher seropositivity rate because the vaccines obviously added to the seropositivity. But even amongst those vaccinated, probably 70% of them would have had hybrid immunity based on the seropositivity in the unvaccinated group. So the experience in South Africa was a massive decoupling. Although the number of cases that were being reported was high, we saw a substantial reduction when it came to hospitalization and death. And what these figures basically report on is a percentage, which the percentage of cases or death or hospitalization that particular wave is responsible for since the start of the pandemic. The number in parentheses is the incidence per 100,000. So if we look at particularly the Delta variant wave and the Omicron dominating wave, what we see, and I'm just going to focus on hospitalization and death, is that a Delta variant contributed to 44% of all of the hospitalizations throughout the course of the pandemic. The Omicron variant only contributed to 10% of all hospitalizations in the start of the pandemic. Even more striking is when looking at mortality, people that have died of COVID-19, and this is excess mortality, 50% of that excess mortality was reported during the course of the Delta variant wave, and only 3% during the course of the Omicron wave. So across the country, about 7% of all deaths since the start of the pandemic were due to the Omicron variant, and roughly about 45% due to the Delta variant. As I mentioned, what happened in South Africa is we decided not to use the AstraZeneca vaccine in January, in February of 2021. Had we used the AstraZeneca vaccine, not only would have it protected against the Beta variant, which ended up subsiding completely, but that vaccine would have conferred protection against the Delta variant. And these deaths, not all of them obviously, but those people that would have been vaccinated, those deaths and hospitalizations would have been prevented had we used the AstraZeneca vaccine rather than having gone against the WHO advice. And this is an important lesson in terms of moving forward as to how we think of vaccines and what we can expect of vaccines and what we shouldn't expect of vaccines. So those sort of numbers are almost identical in the 50 to 59-year age group, as well as the 5 to 19-year age group. And this is one of the early narratives that appeared with the Omicron variant was that children were being disproportionately affected this time around. They were more likely to end up in hospital. They were more likely to die. And certainly that was not the experience in South Africa. What we see in children less than 5 years of age, both hospitalization as well as death, is that it's almost not noticeable on these waves. It's sitting at extremely low rates of hospitalization and death throughout the course of the pandemic, including during the course of the Omicron wave. And what we see overall is that incidence of hospitalization and death in children is substantially lower. Death rate sitting at 10 per 100,000 throughout the course of the pandemic in children less than 5 years, compared to 1,325 per 100,000 in the greater than 60-year age group, and also substantially lower risk of being hospitalized. So what we're experiencing right now is another resurgence, what we're terming as the fifth wave, where positivity rates currently across the country is sitting at about 25, 26%. Yesterday, we recorded close to 10,000 new cases, but at the same time, that's a complete underestimate because the amount of testing that's now being done is even lower than the amount of testing that was done in previous waves. And this particular wave now is largely due to the evolution of the BA4 variant. What do we understand of the BA4 variant? So it's unclear yet as to how long this wave is going to last. I'm pretty optimistic that what we're going to experience here is a short, sharp wave and subsiding very rapidly, and an experience not too dissimilar to what we experienced with the Omicron variant, and that is relatively low number of hospitalizations, low number of deaths, largely because of this high force of infection that has transpired. What we're sitting at currently in South Africa in a sero survey we just concluded is that the positivity rate in people that were not vaccinated after the Omicron wave is sitting at 85 to 90% now. So almost all South Africans, 9 out of 10, have been infected at least once. And that past infection induces protection against severe disease, including against Omicron and almost certainly against BA4 and BA5. So we're probably going to experience a short wave. It will probably peak very soon and then subside. What do we know of the BA4 variant? We know that it is relatively antibody evasive, and in fact also antibody evasive in relation to antibody that's been induced by infection due to the Omicron variant. And these are data looking at people that were infected with Omicron, either stratified by whether they were vaccinated or unvaccinated. And in both instances, but more so in those that were unvaccinated, there's a lower default decrease of neutralizing antibody against BA4 compared with against BA1 is about 7.5-fold, both for BA4 as well as BA5. If you were vaccinated, this fold increase is slightly lower, about 2.6 to 3.2-fold decrease. So what we're seeing is that BA4, BA5, the reason it's probably gained traction is that it is able to evade immunity, including immunity that was induced by past infection over the past 3 to 4 months due to Omicron. So this increase in cases is somewhat anticipated, despite a large percentage of the population having developed immunity either from infections or with vaccines. So where to next? And where to next is a really important question we need to address globally and including in South Africa. We've seen many high-income countries pretty much lift all of their restrictions and gotten rid of most of the regulations around COVID-19. It's not because they've got better immunity than middle-income countries because they got higher vaccine rates. Like I show you, the data strongly shows that infection-induced immunity works as well, and at times even better than just only vaccine-induced immunity. So yes, high-income countries might have reached 85 and 90% vaccine coverage, but inadvertently, we've got the same type of immunity against severe disease by virtue of infections that have transpired. We can do better by getting people vaccinated, especially high-risk individuals, because that hybrid immunity will confer additional advantages. But we can't continue pretending that we're in the face of the pandemic that existed 1 year ago or 2 years ago. So the type of regulations that are still being promulgated in a country such as South Africa is simply agnostic to the reality that the impact that those restrictions are having on other aspects of society, including on the economy, including on the livelihoods of people. And it seems that we've been just simply oblivious, agnostic to the reality and to the experience of the past, and still continue pursuing regulations which have failed dismally, not just in South Africa, but many other resource-constrained countries in preventing infections. Had those regulations worked, we wouldn't have had 85 to 90% of the population having been infected with the virus at least once, not just in South Africa, but also in India and many, many other low-middle-income countries. Unfortunately, it's a bitter pill to swallow, but those regulations, lockdowns, and even the type of masks that are used and masking and restrictions simply, unfortunately, haven't done much in preventing infections from transpiring, or we wouldn't end up with high seropositivity rates. So in conclusion, Omicron was much more transmissible, it was antibody evasive, but there was relative preservation of the T-cell responses. And the same thing probably now applies for the BA4 sublineage, which is circulating. And like I mentioned, for many countries, what we're seeing is that this past infections, high force of past infections, confers protection against severe disease due to Omicron, even if not protecting too well against infections. And that includes past infections due to the Beta variant, due to the Delta variant, due to wild type. The type of decoupling of infections and severe disease that was observed in South Africa is a combination of immunity that arose because of vaccine rollout, but also because of infection-induced immunity. And in fact, as I showed you, most of the immunity in the South African context is infection-induced immunity, which has come at huge cost again, at the loss of 300,000 lives. But at the end of the day, what we're sitting with right now is 85 to 90% of the population have got this infection-induced immunity, which does protect against severe disease and death. But you can do better with hybrid, vaccinating, even those that have been previously infected, because that hybrid immunity, as I indicated, probably would also protect against, confer protection against mild COVID due to Omicron. So we can expect further resurgences. We do, future variants are almost predictable, but the chances of these variants being able to evade T-cell immunity, in my mind, is very low. And if that does materialize, in the unlikelihood of that materializing, that takes us back to March of 2020. And for all intents and purposes, we can rename COVID-19 to COVID 2022 or COVID 2023 if such a variant evolves. So I think it's extremely unlikely that we're going to see a substantial amount of mutations that are going to be able to evade T-cell immunity, and especially T-cell immunity that is induced by past infection, because the breadth and the depth of that T-cell immunity is much more extensive, including targeting the N protein. So I do believe that countries such as South Africa and many other countries where they still continue pursuing regulations, unless you're countries such as China, or a country that's still pursuing a zero COVID policy, which I don't think is sustainable, there's good reason to do what is being done in many high-income countries, and that is accepting to learn to live with the virus, continue vaccinating people, but realize that we're in a very different phase of the pandemic, and many of the regulations that currently exist and that currently still continuing in South Africa is coming at a huge cost in terms of damage to the economy, at a huge cost in terms of affecting the livelihoods of people. So thanks for the opportunity, and happy to take any questions.
Thank you, Dr. Shabir, for that wonderful presentation. I look forward to questions from our audience.
Ask a question.
Yes.
Dr. Manisha, actually, my question is, after 2 doses of vaccine, say AstraZeneca, followed by an Omicron infection, then say government in India says 3 months later you can get another booster. But my question to you is, how much would be the hybrid immunity offered by Omicron plus 2 vaccines that one should go in such a hurry for another booster within 3 months? Is it worth it? Is it derogatory, or it is irrelevant?
So I think that's a really good question. And as I indicated, with hybrid immunity, and I didn't show you the other data, is that in fact, even a second dose of vaccine in an individual that have been previously vaccinated does very little in increasing the neutralizing antibody responses compared with after just a single dose of vaccine. So when people have been previously infected and receive a single dose of vaccine, their immune responses are better than people that have received only 2 doses of vaccine without past infection. And there isn't too much additional gain by giving a second dose of vaccine, at least not when given in the space of 4 to 12 weeks after the first dose. But in direct response to your question, with hybrid immunity, you've got substantial protection against severe disease. And especially if you had 2 doses of vaccine with and been infected with the virus. But at the same time, if you are at high risk of developing severe disease, if you're immunocompromised, if you've got underlying medical conditions, and if you're wanting to optimize your protection against symptomatic COVID and not just against severe disease, then I think there might still be a case for additional booster doses of vaccine, but not for the general population. It needs to be very targeted. It needs to be targeted at those individuals who we believe that the immune responses to infection as well as to vaccines might have been suboptimal and that still remain at risk of developing severe disease. But at the general population level, I do believe that it's almost a waste of vaccine and actually a waste of resources. Because when we try vaccinating large percentages of the population, what ends up happening is that we start redirecting scarce resources to roll out COVID-19 vaccines and inadvertently end up neglecting other healthcare issues. So I don't think there's a case for routine third dosing of individuals. And in fact, the data from Israel shows quite convincingly that giving a third and a fourth dose, in fact, only confers transient protection against Omicron when it comes to symptomatic illness. It might have additional protection against severe disease, especially for high-risk individuals. So I don't think as a general rule that third doses of vaccines are warranted when there's extensive amount of hybrid immunity. And like I mentioned, with 85 to 90% of the population having been infected at least once, including in a country such as India probably, everyone that is vaccinated now essentially is pretty much has got hybrid immunity. And the other issue is that the timing of those doses, it doesn't help much to get a third dose of vaccine at the end of a wave. Because by the time the next wave arises, there's going to be waning of antibody. So if you're wanting to get additional doses of vaccine, it needs to be timed to the time of round about the start of a resurgence, rather than being indiscriminately used way before resurgence transpires, because by the time that resurgence transpires, there's waning of antibody, and we might have a new variant that is evolved by then.
That's a great advice. Thank you.
Dr. Bukhari, yes, go ahead.
Thank you very much. First of all, I am very thankful for such Dr. Shabir Ahmed from such a very elaborate and effective lecture. I am Professor Bukhari from Pakistan. I have 2 questions. One of the question is that from the way there was a news from the Bill Gates that he was warning another variant which may be more transmissible and more fatal. This is the one. Is it a false news, or you are expecting another pandemic? Related to this one is another question. Do you think why is more variants are developing in South Africa? Because in Pakistan, we are almost finished with this COVID. And do you think that if the new variants are some new pandemics, the scientists are thinking about some new vaccine, or they will use this vaccine? Thank you very much. These are a few questions to me. Thank you, Dr. Shabir. I'm waiting for the call.
So on the first issue about whether we're going to experience a new variant that's more transmissible and more virulent, we're certainly going to have new variants. But I think anyone that predicts what the next variant is going to look like is going to be disappointed, because as we've seen in the past, we've been largely unsuccessful in predicting what variants are going to evolve and how they're going to pan out. The Omicron was being painted as a worst case scenario, a complete disaster. And as it turned out, it's a variant that was more transmissible, was antibody evasive, but didn't cause large number of fatal cases or hospitalization. Not because the variant was necessarily less virulent, but because of this evolution of immunity that has evolved over time. So yes, there will be new variants. It might be more transmissible, but whether, like I mentioned, whether those variants are able to evade T-cell immunity, I'm highly optimistic it won't. And like I said, if it does evade T-cell immunity, then all of the vaccines that we've got and all of the past infection that has induced immunity comes to naught. Then we go back to March of 2020, because we're dealing with a substantially different virus. And because of the large amount of infection-induced immunity that includes targeting epitopes of the N protein and M protein, I strongly believe that the chances of a variant evolving that is going to end up causing more severe disease cases and death than transpired with Omicron is very unlikely. With regard to the next generation of vaccines, we certainly already have started studies, including elsewhere, where we are now looking at combining both the S protein as well as the N protein. So becoming more diverse in the antigens that are included in these vaccines to enhance the breadth of the T-cell responses in particular. And I think I'm less of a fan about trying to develop vaccines targeted at a specific variant, because by the time we've got vaccines in the clinical space, the virus has moved on and we've got a new variant. So it's really trying to broaden the breadth of immune responses that can be induced against COVID-19, and that is this combination of S and N protein RNA vaccines that are currently being evaluated.
Thank you so much. Can we have more questions, please? Dr. Angelica, please.
Thank you so much. Good morning, and thank you so much, Prof. Ahmadi, for an excellent presentation. I just need to, or just help me out if my understanding is then correct, because this is also what we are seeing in the surgeries. So we need to make sure that the patients there or the public understands that even though you had previous Omicron, you can, with the B4 variant, subvariant, get another sort of Omicron infection, you know. So it's no guarantee, but it's mild disease. So regardless whether you have been vaccinated before or had any other variant before, you can still get mild disease. We should make the public aware so that they can understand that part. And I think in that, herd immunity for mild disease will also wane down. And again, we need to be clear on that, if my assumption is correct. However, against, as you said, the T cells and the long or the severity of the disease, there you are protected, whether you are at hybrid immunity or only had previous infections or only been vaccinated. So that we are clear on that part. And as you correctly said, we need to make sure that people understand why we are vaccinated or advise them to get vaccinated, not to escape mild disease, but to prevent them from dying. Am I correct in this? Thanks.
Yeah, so that's correct. So if you have been previously infected with Omicron, and the estimates in South Africa is that close on to 40% of the population were actually infected during the course of the Omicron wave. If you have been previously infected, and especially if you're unvaccinated and you've been infected more than 3 to 4 months ago, it's very likely that you are still at risk of being infected with a BA4 lineage, but that infections will probably be asymptomatic or result in mild illness, unlikely to land you in hospital. If you've been vaccinated, plus you've had Omicron infection, then you're probably less likely to have symptomatic COVID-19 due to the BA4 variant, and obviously also less likely to be hospitalized. And like I mentioned, for countries to still continue chasing after getting 70% of a random population vaccinated, that has absolutely no merit at all, because we've got that level of immunity already against severe disease. The focus in all countries, in my mind, especially countries which haven't yet rolled out vaccines substantially, to get more than 90% of people above the age of 50 vaccinated, which is significantly lower numbers, and getting 70% of the random population vaccinated was simply not going to contribute to large numbers of hospitalization and deaths because of their low risk to start off with, coupled with the reality that they already do have protection against severe disease and death from past infections.
Thank you. Yes, Dr. Manisha, you have another question?
Yes, my question is, since these vaccines had come up against the earlier variants, starting from Wuhan virus, so the present vaccines that are available for third, fourth booster, or even second, first, are they, as per your charts, they are not as effective in Omicron as they were in the previous wave. So what is your comment? Are they tweaking the vaccines enough to be effective for Omicron and the future variants?
Yeah, so like I mentioned, it really depends why you're using the vaccines. If you're using the vaccines to prevent the sniffles and to prevent the runny nose, then these vaccines are completely useless to an extent. But if you're using these vaccines to protect against severe disease, even against Omicron, as I showed you, as well as, like I believe, against future variants, these first generation vaccines will still protect against severe disease and death due to Omicron as well as other variants. But at the same time, I do believe there's a need for a second generation of vaccines, which are the vaccines that are currently being evaluated, which targets more epitopes than just those of the spike protein. So it depends why we're using vaccines. We're not using vaccines to prevent the sniffles. We should be focused on using vaccines to protect against hospitalization and death. About the other issue that people argue why everyone should be vaccinated is because people develop long COVID, which is a real reality, which is a reality. But we don't know any longer as to whether the risk of developing long COVID now, when people have got immunity from past infections or have been vaccinated, is actually same compared to the risk of developing long COVID in an absence of immunity. And in fact, we do know that vaccines alone actually reduces the risk of long COVID when there are breakthrough infections. So I don't think that the whole notion that we're trying to prevent long COVID, and that's the reason why we need to vaccinate everyone, including children, holds much water, because I do think that we in a different phase now, where even the risk of developing long COVID is reduced by virtue of the underlying immunity that has evolved from infections as well as vaccines.
Thank you.
Okay, so Dr. Akhtar.
Thank you very much, Prof. Mani. It was a really very informative presentation. And my question, Prof, is about the mask. Children wearing masks in the school, not wearing masks, adult must wear masks, indoor, outdoor. Prof, what is your opinion on that? Thank you.
Yeah, so I've been speaking about this nonstop for the past 3 days. So I think you have heard my opinion. So the bottom line is that masks work, but masks only work if you're using the right type of mask and if you're wearing it properly. So you need to be using the N95, the KN95 mask, and you need to use it correctly. And you can't be taking it out when you're in a room to have tea. You need to use it with other people. You need to use it correctly all of the time, especially when indoors. Believing that we're actually achieving much by asking children to wear masks when they're in school is again being completely agnostic and dismissive of the reality. Had those masks been working in children, in protecting them from being infected, we wouldn't have had 2/3 of children being infected with the virus at least once before the onset of the Omicron wave, and that probably sits at 80% now. So just asking children to wear a mask in class, when once they're out of class, they're not wearing a mask, they go to other indoor spaces, they're not wearing a mask, they get infected, doesn't achieve much. But in addition to which, the type of masks that are being used by the majority of South Africans are these cloth masks. And the cloth mask does not protect you against infection. It doesn't reduce the chances of you disseminating the virus into the environment because it's got low ability to filter out microparticles. So we continue pursuing policies which simply the data shows us, it's not me saying it, the data shows that it hasn't protected or reduced infections from transpiring because had it reduced reduction in transmission, we wouldn't have 85 to 90% of the population infected at least once. Children are extremely low risk of developing severe disease. So again, it's difficult to understand why we're getting them to do something which probably is to their detriment in terms of social engagement, in terms of just even learning in the school space. The short answer, I see very little value to be using a mask for children. For high-risk individuals, when there is a resurgence, when they are indoors, they certainly should take additional protection, wear a proper type of mask and wear it correctly.
Thank you. Yes, can you ask a question, Mr. Muniswa Sabman?
Can you hear me, sir?
Yes, please ask your question.
Okay. Very well done, Dr. Shabir. It's one of the most wonderful subject, and you have very nicely explained everything. Only what I just wanted, one of my previous speaker already asked about the mask. This the Korean variant, because I am a practicing doctor of this general physician. I see a lot of, even twice I became infected with COVID-19, and what I just feel that is this social distance, mask and travel restriction and all this vaccination and COVID testing, is it mandatory, should be mandatory to all the developing countries to travel? And second thing is, this COVID-19 is so much so, is variants are go on evolving, and WHO is doing their best, and even in India we are doing lot of vaccination has been done to the most of the persons. But still we are having COVID positive cases. It's rampant. In Delhi, Mumbai and Bangalore, we are getting a lot of cases. When it will be going to be end? Can you please throw some light on this, Dr. Shabir ji?
Yeah, so like I mentioned, I mean, all of these regulations does very little in protecting people from being infected or limiting the amount of virus that is transmitting. The most important measure that you can take, especially when indoors. So firstly, the majority of infections that do transpire are infections that are occurring indoors. More than 80% of infections are because of indoor gatherings or indoor interactions. There's very little chance of being infected when outdoors. But when indoors, the most important measure, unless you're wearing an N95 or a KN95 mask and wearing it correctly, the most important measure to reduce the chances of rapid spread of the virus and large outbreaks is ventilation. Much more important than physical distancing. For a virus that's transmitted through the airborne route, it's less about direct inoculation between people, but rather suspended virus particle in the environment, which people are inhaling or landing on mucosal surfaces that are resulting in infections. So asking children to space themselves 1 meter apart in a class or 1.5 meters apart in a class as an example, when there's poor ventilation, achieves absolutely nothing because they're still going to get infected irrespective of whether they're sitting on top of each other unless there's good ventilation in that space. And many of the other regulations, like I said, We should stop believing that they work, because had they worked, we wouldn't have 85 to 90% of the population being infected with the virus at least once. When it comes to vaccines, like I mentioned earlier, it depends why we're wanting to use vaccines. What I didn't mention is that for healthcare workers, you're wanting to probably optimize your protection even against mild COVID. And I think there's a good case to be made for healthcare workers to be vaccinated, to get additional doses of vaccine, be it a third dose or a fourth dose, at the start of the time when there is a resurgence in that country. Because you're wanting to optimize your protection against even mild COVID, because when healthcare workers go off work, it obviously impacts on healthcare facilities in addition to just impacting on themselves. So we're wanting to safeguard healthcare facilities. So I do believe there is a role for healthcare workers to get additional doses when there is a resurgence, so we can minimize the number of healthcare workers that end up getting sick with COVID-19 and then needing to go off work at a time when there's a resurgence, which puts pressure on healthcare facilities. So I hope I answered your question, but like I said, many of these regulations have not worked in preventing spread of the virus significantly, and they're doing more harm than good.
Thank you very much.
Hi, Dr. Muzukwa, you have a question?
No, thank you so much. I just dropped my hand after realizing that my question was answered, from the other participants.
Okay.
Thank you.
Okay. Dr. Monica?
Thank you so much, Dr. Mahdi, for an incredible summary of a very, very large amount of data, and using your personal experience and vision of what you've seen in South Africa in terms of how we extrapolate it to the world. What I found very interesting about your conversation was talking about the timing of the appearance of the vaccinations, the decisions that were made on a societal level about the approach towards vaccinations and the outcomes of using the same vaccinations in other countries, and understanding that it is a moving target. What is the virus? Where is the variants happening? What are the vaccinations, and what's the level of immunity that you've achieved, whether it be through hybrid immunity, vaccine immunity, natural infection immunity? I think what you have said has been very pragmatic. I believe that you've provided a view and a lens to the entire pandemic that was a fantastic summary with a lot of granularity. So I want to say thank you for your insight. I think it's impossible to predict where we are going to go with the pandemic. I agree with you that it's going to be very dependent, and we need to uncouple the death, mortality, excess death from the number of infections. And as we start seeing that uncoupling of the process, we are going to see the long tail, but it will be a tail to the pandemic as this becomes endemic. I think the only question that I would have for you, and it was something that you said about not using immunization to prevent long COVID, but to prevent more so infections related to moderate to severe disease and mortality, if I am summarizing correctly. I am quite concerned. I work as a clinical allergist and immunologist, and in the current wave, I am now seeing patients who are reporting prolonged symptoms, even from the ancestor virus all the way through Alpha, Delta, and the phases of Omicron. And where we are facing in the decision in the United States, where currently the second booster dose is available for those who are 50 and older, primarily with the mRNA vaccines. Johnson & Johnson just got, which is the other viral vector-based vaccine, got its kind of restricted recommendations recently. Do you not see a role of having, even if it was a short-term benefit, of utilizing the short-term benefit immunizations to prevent the potential of long COVID symptoms that we are beginning to see with milder infections? I think the morbidity of infections have been very high, and I'm now concerned that as the death rate goes down, that the morbidity associated with mild infection and the form of long COVID is something that we are still yet to see as the next pandemic.
Yeah. So Monica, perhaps I should be more explicit and clarify what I was saying around vaccines and long COVID. So the type of examples that you cite, and long COVID is a real entity and it is a reality. I don't think we've adequately characterized what percentage of people that are infected end up with long COVID, because there are biases in terms of who is being diagnosed. And like I mentioned, in a country such as South Africa, where 85% of infections are asymptomatic, so they wouldn't be diagnosed. So as a percentage of diagnosed cases of long COVID, it might seem high, but when adjusting for undiagnosed cases, the rate of, or the prevalence of long COVID would be lower. But that does not diminish the importance of long COVID. But what I'm saying is that the type of experience that you've just cited, where someone has got infected with the initial wild-type virus and still has persistent symptomatology, that individual got infected with the virus at a time when that individual was relatively naive. We do know that vaccines, when rolled out in the context of a relatively naive population, they actually do reduce the risk of long COVID. So that is a given. But what we face with right now is a very different situation compared with what existed 1.5 years ago, in that we've got extensive immunity which has been induced by infections as well as vaccines. And what I'm saying is we don't know whether the risk of developing long COVID, when there's underpinning immunity against COVID-19, be it from vaccines or from a past infection, whether the risk of developing long COVID now is the same in individuals with reinfection and breakthrough infections compared to infection in a naive individual. And I do believe, and I had COVID-19 about 3 to 4 weeks ago. It lasted for about 3 days. I'm completely well. I might be that example of someone where vaccines really work. It protected me from ending up in hospital. And I think that is what I'm saying, is that we don't know what the risk of long COVID is now when there's such extensive underpinning immunity against COVID-19 that's resulted from infections as well as vaccines, compared to what the risk of long COVID was when people were being infected the first time around.
Thank you. Thank you very much.
Thank you so much. Anyone on the floor have a question? I think it's a very good session and extreme useful for everyone. Do we have more questions? Okay, Dr. Shabir, it was a very nice session and a very useful information. We request you to be a part of this SIMAO sessions on a regular basis. I will ask Dr. Akhtar, if you want to be a part of the group, we can add you there. And I think vaccination and everything is something which will even continue after the pandemic. So, whatever knowledge you will share is very useful for us. If anybody else has a question, otherwise we'll wind up the session early today. Not that it's early, but yeah. Okay, Dr. Shabir, thank you so much. Any take-home message you have for us?
No, like I said, I think we need to become a bit more optimistic about where we're heading. The pandemic is not over, but we are at the tail end of this pandemic, and I still remain very optimistic that we're never going to experience, at least not with this virus, like anything that we experienced as an example during the course of the Delta variant wave. But again, the other important lesson is that the next time around, when there is a new virus, when there is a new pandemic, we need to have learned from the lessons of this pandemic, and we also need to start working on preparing for that next pandemic at multiple levels.
And do you think the vaccination which are available can go for a modification that quickly or for the next variant if it comes ever?
Yeah, like I said, for COVID-19, there is a second generation of vaccines, which I think will probably start becoming available towards the end of the year. So I am optimistic there will be a second generation of vaccines that might do better than the first generation, even when it comes to protecting against mild COVID-19, as well as being more resilient when there is further variants that arise.
Great. Dr. Shabir, I just want to ask a last question, and before we end the session, do you specify any age where people should avoid vaccination after a certain age, let's say after 90 or after 85 or something? they should avoid a vaccination or a booster dose?
No, absolutely not. After in that age group, you're probably requiring 4 and 5 doses of vaccine rather than only 2 or 3 doses. Because they're immunocompromised, they need to get that additional booster. Patients with cancer, as an example, 2 or 3 doses of vaccine, in fact, still induces a lower immune response. And in fact, 3 doses is probably the equivalent of priming in a patient with cancer and probably someone above the age of 70. So those are the highest risk of developing severe disease, and they're most in need of vaccines.
Great. So thank you so much. With this note, we will love to close this session. This was 109th session from SIMAO, an international weekly meeting, and a very important topic covered by Mr. Sabir Mandi. We request him to be a part of the session in future as well. Thank you everyone for joining in. We have about 19-20 countries and we have representatives over the last 2 years with us. So thank you so much for joining in, and see you again next week, same time, same day. See you then.